Laryngocele. Laryngocele refers to dilatation of the saccule of the laryngeal ventricle and is unilateral in the vast majority of cases. On imaging, these lesions are generally characterized as well-defined, thin-walled fluid or air-filled cystic lesions in the paraglottic space. The communication with the laryngeal ventricle is not always identified, and an extralaryngeal extension through the thyroid hyoid membrane may or may not be present. Clinical presentation. When small, the lesions are usually asymptomatic and incidentally discovered when imaging the neck for other reasons. Symptoms vary according to the size and extension of the lesion and may include a sore throat, dysphagia, stridor, neck lump, and or airway obstruction. A little bit about what do you mean by the laryngeal ventricle and the saccule. On each side, now this is the false chord, this is the true chord, and in between is the laryngeal ventricle. On each side, the mucosa of the middle cavity bulges laterally through a gap between the vestibular and vocal ligaments, and that gap, protrusion or projection, is called the laryngeal ventricle. Now, tubular extension of each ventricle is called the laryngeal saccule. Now, this projects anterosuperiorly, I repeat, anterosuperiorly between the vestibule and the vocal and the thyroid cartilage. Between the false chord and the true chord is the ventricle, which, when protruding anterosuperiorly, that is called the saccule. Now, within the walls of these laryngeal saccules are numerous mucous glands. Mucus secreted into the saccules lubricate the vocal folds. The laryngeal saccule is a mucosa-lined pouch that arises from the anterior aspect of the roof of the laryngeal ventricle. It is most prominent in newborns but involutes during childhood. If an external component is noted and compressed, a hissing and a gurgling sound may be produced, and this is called the Bryce sign. Epidemiology. Almost all laryngoceles are unilateral. Only 8 bilateral cases have been reported in the medical literature. The incidence appears to be equally distributed between men and women, and they are most common in mid to later life. Pathology. Laryngoceles are usually acquired rather than congenital. They are lined by pseudostratified columnar ciliated epithelium. Occasional areas of stratified squamous epithelium with or without submucosal serous and mucous glands may be present. Now, this is a combined internal as well as an external laryngocele. 3 laryngocele subtypes are described. Internal, the dilated ventricular saccule is confined to the paralaryngeal space. It is contained by the thyrohyoid membrane. External, the saccule herniates through the thyrohyoid membrane and the superficial portion is dilated. And there can be this is a mixed laryngocele. Both the internal and the external component is present with both internal and external components. Now, that is a neck mass and this is an external laryngocele. And when we compress, you might get a hissing sound that is called the Bryce sign. What is to be differentiated from saccular cyst? These saccular cysts represent 25% of all laryngeal cysts. Now, the anterosuperior projection of the ventricle is called the saccule, and when the cyst happens, it's called a saccular cyst. They are also fluid-filled dilatations of the laryngeal ventricle, but do not communicate with the laryngeal lumen. This is how we differentiate it from a laryngocele. Saccular cysts do not communicate with the laryngeal lumen. So therefore, what are the differences between a laryngocele and a saccular cyst? A laryngocele is filled with air, more common in adults, and communicates with the laryngeal cavity, whereas saccular cyst is filled with mucus, more common in children, and does not, I repeat, does not communicate with the laryngeal cavity. Risk factors: increased intralaryngeal pressure. Secondary to what are the risk factors to develop a laryngocele? Increased intralaryngeal pressure, secondary to excessive cough, playing woodwind or brass instruments, glass blowing, obstructing lesions, example a tumor, childbirth, which is rarely reported, and the finding of a laryngocele should prompt a search for an underlying laryngeal carcinoma obstructing the orifice of the laryngeal ventricle. Secondary laryngocele is the term used when a tumor is the cause of a laryngocele. Treatment: surgical excision may be necessary if a laryngocele is symptomatic. Complications: infection. Infected laryngocele is known as a pyolaryngocele, and this occurs in about 10% of laryngoceles. The infection within a laryngocele can spread to adjacent head and neck spaces and can lead to supraglottitis, increased risk of laryngeal carcinoma. Now, that is a laryngocele. Here we find a well-defined, thin-walled, air-filled cystic lesion seen in the right paraglottic space, communicating with the laryngeal ventricle. An extralaryngeal extension through the thyrohyoid membrane is seen. Similar yet smaller, well-defined, thin-walled, air-filled cystic lesion is seen in the left paraglottic space, communicating with the laryngeal ventricle, and no extralaryngeal extension. Now here, what is your opinion? Right combined external and internal laryngocele, left internal laryngocele. What are the risk factors? Raised intralaryngeal pressure, secondary to excessive cough, playing wood, wind, brass instruments, glass blowing, obstructive lesions. The finding of a laryngocele should prompt a search for an underlying laryngeal carcinoma obstructing the orifice of the laryngeal ventricle. Microlaryngoscopy involving the use of carbon dioxide laser has become the main therapeutic procedure for the treatment of internal laryngocele during the last 20 years. An external approach still remains the main therapeutic approach for the treatment of combined laryngoceles. Now here we have a comprehensive overview of laryngoceles.